All right. So SIADH-DI, it's a disorder of the posterior pituitary gland. So what does the posterior pituitary gland do? Yep, it excretes antidiuretic and oxytocin. Okay. So ADH is that antidiuretic. Diuresis means to what? Pee. So if we're anti-pee, right? And oxytocin. So if we have a disorder of the posterior pituitary, and its job is to excrete ADH, we have a disorder of ADH, right? And ADH, which is known as vasopressin or AVP, it regulates water balance and osmolality. That's important. Serum and urine osmolality, I can't talk now after my apple, is affected because there's something wrong with ADH. Yeah. Thank you. So we either have an overproduction of it, too much ADH, so too much anti-P, like SIADH, or we have too little, underproduction, DI, diabetes insipidus. Does diabetes insipidus have anything to do with diabetes? No, nothing with your sugars, okay? All right, so syndrome of inappropriate antidiuretic hormone, SIADH. So what's going on? We have too much of the hormone, correct? Too much ADH. If we have too much ADH, what do we think is happening to the fluid in our body, the water? It's staying, right? So we got too much. So there's increased water being reabsorbed in the renal tubulars. The whole patho that goes into the book is that ADH increases the permeability of it, and that's why more water is reabsorbed. But basically, you just got too much water. So your fluid volume is going up, right? And again, everything in your body works in this balance. We want some retention of fluid, right? We don't want to get rid of all our fluid, but we don't want so much retention that we have an overload. So with SIADH, there's too much. And the reason we talk about SIADH and DI during this is because a lot of times when you have the head injuries that we talked about, or brain tumor, or whatever, they cause these syndromes. So it may be something that you have to deal with your head injury patient. So typically it happens, because right here, I get ahead of myself. It can happen with older adults in malignancies, head trauma or certain drugs, or any tumor or metabolic disorders. So the reason why we study this here is because a lot of what we talked about can cause this syndrome. Bless you. Oh, she's got a cute sneeze like you, Amanda. All right, so clinical manifestations. So what are we going to see? We have fluid retention, right? So we have water coming back into circulation. Too much. So what do you think is going to happen to your serum osmolality? Down, right? Because think of it like this. Think this is your vessel, right? And you have, let's say, little water, 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 water. And then you have your molecules at equal, 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 equal. That's your osmolality, right? That's normal osmolality. If all of a sudden you have a bunch more fluid coming in, more water, because you're retaining, what just happened to your osmolality? It dropped, right? So you have a serum hypoosmolality because fluid is being retained. Those molecules that we're talking about is something like sodium. So what's happening to your sodium level? It's decreasing, right? Did it actually decrease? Did I take away any of those red little dots? No. It's dilutional. Yeah? So what's a normal serum sodium level? 135 to 145. So we are going to see sodiums lower than 135, right? When we have low sodiums, what kind of signs and symptoms are we going to be seeing? Muscle cramping, twitching. So is your patient going to come in, or are we going to give you a scenario that says, they're going to come in and be like, excuse me, I'm having SIADH right now, and I'm hyponatremic. No, they're going to tell you, I had a head injury 2 weeks ago. I'm dying of thirst. I'm having all this cramps in my leg. Okay. What's going to happen to their urine? That's going to be super concentrated. So this is what's happening. Oh, let me get rid of that. This is what's happening inside our body, right? With the urine, it's the exact opposite because we're taking away all that blood or all that fluid, I'm sorry. So let's just say this is your urine, a drop of urine. So you're going to have a little bit of water and a whole lot of molecules, right? It's going to be super concentrated. And you're not going to have a lot of urine output to begin with because your body's retaining it all. So if you're retaining a lot of fluid, what do you think is going to happen to your weight? It's going to go up, right? Yeah. Is it right? Okay. Sometimes they can have vomiting, abdominal cramp seizures if we're going to get real bad. If it's not treated, the reason it becomes a problem is because we can develop cerebral edema, lethargy, headache, confusion. These are all, like, if it starts getting really bad. But in the beginning symptoms, again, we want to catch things early, right? This is our job, prevent it from going any further. So we're going to have patients that are going to complain of some muscle cramping. They're going to say, I'm super thirsty. I'm feeling a little nauseous. I'm not peeing as much as I used to. So how do you think we diagnose it? Your patient comes in and they tell you that they've got these signs and symptoms. How are you going to verify it? What labs? I love when you all tell me that. UA, the specific gravity, and the urine osmolality, right? So urine and serum osmolality. The serum is going to be what? Low. Low. How low can you go? And the urine specific gravity is going to be high. That's so like urine sodium is going to be high. Serum sodium is going to be low. And that's because of that dilutional effect. And this is a good point in general, just like when you guys were, this is what we wanted to see on your functional dimensions. When you guys just start screaming out labs like CBC, like that's great. But what are you looking for in that CBC or UA? What are you looking for in that UA? That's where we want to see those pieces come together for you guys. Okay?
Dr. Daniel.
Uh-huh.
So the urine specific gravity will be above 1.030 and the serum, I'm confused. The serum what? Sodium?
The serum sodium, so intravascularly, serum sodium is going to be low, below 135. But in your urine sodium is going to be high. I wouldn't forget too much about the number. Just know that it's going to be high. All right? Because so everything in urine is going to be super concentrated because there's not a lot coming out. And everything serum is going to be diluted because you're retaining it all.
Serum meaning the sodium.
No, serum meaning like fluid intravascularly.
Okay.
Mm-hmm. Does that make sense? So, what are we going to do to treat it? We always want, how do we treat something? Treat the cause, right? Treat the underlying cause. There's some meds on page, I think it's still page 1193. I'm going to have to change that once we go to the 10th edition. I think there's a box in there. They're meds that stimulate the release. So if we have a head injury, we're going to treat the head injury. If it's a med cause, we're going to treat that. If it's a malignancy, that's why we treat the malignancy. If it's mild, if it's just a mild case of SIADH, then they're typically on fluid restriction. Why we're treating the underlying cause. A lot of what we're going to talk about in level 4 is it's a problem from something else. Does that make sense? So SIADH is a problem because of a head tumor, because of whatever. And in order for us to, the main way we treat that is by treating whatever caused it in the first place, while managing symptoms and making them not worse. All right? If it's severe, like if they have severe hyponatremia, we need to replace it, right? Because that severe hyponatremia is going to be causing the seizures, the cramping, everything else. So hypertonic, IV hypertonic if sodium's less than 120. What does a hypertonic solution do? Draws the fluid.
Into the intravascular space.
Yep. I know, I'm sorry. Stand down. Yes, you were right. I just wanted, this side wasn't saying it. I wanted to hear it too. So, yes, it's going to draw water out of the cells, right? So that we can start getting rid of it. IV Lasix, if the sodium's greater than, but the sodium has to be greater than 125. And they're typically on a really strict fluid. I would die with this fluid restriction. Oh my God. I drink so much water. 500 mLs a day. Less than 500. So that is like one water bottle. That's all they can take the entire day. That includes any liquid. So your coffees, your Monster drinks, your whatever. Yeah, that one bottle is what they can have the whole day. That's all fluid intake. It's making me thirsty doing it. If it's chronic, they're going to have teach the patient about fluid restriction. They're going to have to supplement their diet with sodium and potassium. We want them to teach signs and symptoms of fluid and electrolyte imbalances. Like if they start developing cramping, that should be a red flag to them that, oh, my sodium might be getting low. I need to go see my doc, or I need to increase my supplements, because if not, it could lead to seizures or something more significant. Of course, we're really going to monitor eyes and O's, right? Vital signs, lung sounds. What are they going to sound like if they're fluid overload? Five. Mm-hmm. Your serum sodium has to be greater than 125 in order for you to give the Lasix. So we're going to monitor fluid status big time, right? They've got too much fluid on them. They're not having a whole lot out. We want to be really careful about like monitoring their urine output. How are they sounding? And daily weights. All right, so SIADH, too much ADH, fluid retention, everything inside's getting diluted, everything coming out is hyperconcentrated. All right. An opposite DI, diabetes insipidus, which has nothing to do with diabetes. This is too little ADH. So either we have too little, there's an actual deficiency, or the kidneys aren't responding to what ADH we have for whatever reason. So no water is getting reabsorbed in the renal tubulars. So volume intravascularly is dropping. So low ADH, either from a deficiency in itself or because the kidneys aren't responding to it. Because of that, water isn't getting reabsorbed by the kidneys. So it's just dumping out. You're just peeing it out. So if you're peeing it out, everything inside is getting drained of it, correct? Decrease amount. So types, it can be central, a brain tumor or injury. So that's why, again, that's why we're talking about it. You have some kind of head injury or brain tumor, and that interferes with how ADH is synthesized, so the kidneys aren't responding to it. This typically tends to be more dramatic onset and more dramatic like losses of fluids. Nephrogenic, what do you think that's from? The kidneys. So you have drugs like lithium that can damage the kidneys. So you have enough ADH, but because your kidneys were damaged, they can't respond to the ADH the way they're supposed to. Or you have renal disease, or whatever reason, there's something wrong with the kidneys that your brain's making the ADH, your kidneys just aren't responding to it. It's okay if you don't write exactly what I write up there. I know the pink is a little hard to see. If you can understand, central is like brain. Nephro is kidney. Remember, the idea is not always to necessarily write down every single thing I write down, but write it down to what makes sense to you guys. What's going to help you best study. And if you do want to write down exactly, because I get it, I'm like that, I like it just so, then you can re-listen to it and get it too, okay? I apologize. I know the pink is not great, but. And primary is just from a lot of water intake. Excessive water intake. Primary is excessive water intake. So it can be central from a brain tumor, head injury, anything that kind of messes with the head, central, brain surgery, that messes up with how ADH is synthesized, how it's made. Nephrogenic means that there's something wrong with the kidneys. ADH is being produced fine, but the kidneys aren't responding to it. Primary is from excessive water intake. All right, so just opposite of what we saw before, right? So you have the normal, this is normal intravascular serum, and you have your little molecules to water, and those are equal. Okay? But now we're losing water. Okay? We've lost water. I'll even be super dramatic. We're down to one little water molecule. Okay? So what's going to happen to my serum osmolality? It's going to be high. So normal sodium is what? 135 to 145, so our sodium is going to be greater than 145. Before we had, with SIADH, we had no urine. Now what's happening to our urine? We are dumping polyuria. Sometimes they can have up to 20 liters a day that they're peeing. Can you imagine peeing 20 liters? That, yeah. That is a lot of peeing. How do you think they're going to feel if they're getting rid of all this water? Thirsty. They're very thirsty. They're feeling dehydrated. They're peeing everything out. They're trying to get their hands on every amount of water they can. So if they can't keep up, if their oral can't keep up with what they're putting out, they're going to get dehydrated. If that continues, they can develop hypovolemia and go into shock. What's going to happen to your vital signs? Blood pressure is going to go down. Heart rate's going to go up. Right? It makes sense, right? If you guys can understand the why of what's happening, you can figure out what to expect to see from your patient. And you can always work your way front and back. So again, how are we going to diagnose this? Same thing, right? How do we diagnose it? The osmolality in the urine. So with SIADH, what was our serum osmolality? Low. What was our urine osmo? High. Okay? So what is our serum osmo for this? High, right? Because look, we've got lots of molecules in a little bit of water. What's going to happen to our urine? It's going to be diluted, right? Because let's say this is a drop of urine right here. We're going to have like all this water because they're peeing their brains out. And then like one molecule. Oh. Okay. So serum is going to be high. The urine specific gravity, serum osmo is going to be low. They have the picture of this nice man who's constipated. All right, so how do we treat? So big thing, obviously we're going to treat the cause, as always. We're going to maintain fluid and electrolyte balance, so we need to replace fluids. We don't want them to get hypovolemic. We don't want them to go into shock. What kind of solutions are we going to use? What kind of solution? Are cells dehydrated? Hypotonic, right? Because we're pushing it into the cells. Is that why Dr. D spent so much time explaining all that? Mind blown. Does it all make sense? It's all coming together? Crap, they do know what they're talking about. Well, sometimes. What are we going to monitor? Vital signs, urine output, mucous membranes, neurostatus. Is this something that we're going to monitor every 4 to 8 hours? Do I want to know that my patient just peed 8 liters, like, in 8 hours? Or do I want to know, like, every hour, every 2 hours, you know, pretty frequently, what their fluid status is? Because they're having large fluid shifts. They're not taking in enough because they're going to be at really high risk of hypovolemia, of going into shock.
What's that after urine output?
Mucous membranes, MM. Not like M&Ms. Mucous membranes. Huh? Yeah. No candy. We're going to give them meds to help decrease thirst. If it's central, so what was central again? Brain, right? Head injury, brain surgery, brain injury. So it's not synthesizing. So if ADH is messed up, what do you think we're going to give them? ADH! There we go. We're waking up. It's almost noon. Come on, y'all. So we're going to have to give them hormone therapy. So DDAVP, vasopressin, we're going to give them what they don't have. Their kidneys want to work. They're just not getting anything. The kidneys are really mad at the brain right now for not giving it what it needs. What if it's nephrogenic? It's how the kidneys, right? So are we going to give them DDAVP? No, because the brain's working, right? The brain's saying, I've got this for you, kidneys. You're the ones who not taking it. So the kidneys are not responding. So we might have to give them diuretics, thiazide diuretics. We need to do low sodium diet because we don't want them to get hypernatremic any more than they are. Indomethacin is an NSAID, and it helps. So these meds help the kidneys respond to the ADH that's there. So we're not going to give them more ADH. They've got it. If it's from a nephrogenic cause. So again, this is why it's important to figure out what's causing it in the first place, so that we can treat the cause, and or so that we can treat them the right way.
How would you differentiate the two?
When they come in, they'll get that diagnosis. The doc will have that diagnosis. Mm-hmm.
So if you were to ask us a question, you would be more specific?
We would, yes. If we're going to give you a patient scenario, and if we want you to be able to tell us the difference between the two, we would give you clues that would tell you.
Okay.
Yeah. Who had a question over here? Nobody? My code, which one? Oh, the DDAVP is the drug. It is, it stands for, yeah, something, Yeah, it's just, you'll know DDAVP. That's not a code for anything. That's the actual drug. It does stand for something, some long, big word, but that's the drug you'll actually see, DDAVP. Who had a question over here? You changed your mind? Okay. Low sodium diet in less than 3 grams a day.
That's a G.
That's a G.
Oh, 3 grams, 36.
I can't hear Jeffrey.
DDAVP is the generic abdominal pressure.
There you go. Thank you. All right. So pretty simple lecture. Does everybody understand? Does it all tie together now? We ready to like ace test one?